Hello everybody, my name is Florian Lagler and I am pediatrician and pharmacologist by training. I do see mucopolysaccharidosis patients here in Salzburg at the University Hospital Department of Pediatrics and also other patients with lysosomal storage diseases. In addition to that, it's my pleasure to run the Medical Simulation Center here at Paracelsus Medical University Salzburg. And in this Medical Simulation Center, we started about 7 years ago to provide simulation trainings for physicians and nurses involved in the management of patients with Hunter's syndrome and other mucopolysaccharidoses. The reason for that is that it's a rare disease and it's particularly important, as you will appreciate a little bit later. It's particularly important to know about the specific risks of these patients to provide safe and best possible practice management to these patients. Today it's my pleasure to hold a webinar together with you on perioperative complications in a Hunter's patient that underwent surgical procedure in the ENT department. This is my disclosure, and to start with, I will give a short introduction into Hunter's syndrome, mucopolysaccharidosis type 2, and then at the end I will give a short summary and an overview on best practice in perioperative management of patients with mucopolysaccharidosis. So, to start with, the introduction on mucopolysaccharidosis. Hunter's syndrome or mucopolysaccharidosis type 2 is one of 7 different types of mucopolysaccharidosis. These belong to the lysosomal storage diseases and are rare diseases. We know about 6,000 to 8,000 rare diseases. We know about around 50 lysosomal storage diseases and 7 different types of mucopolysaccharidosis, with Hunter's syndrome occurring in roughly 1 in 200,000 or 300,000 patients. The disease is caused by a genetic defect, by mutations in the respective gene, and this leads to deficiency in a lysosomal enzyme, which then leads to accumulation in the lysosomes. Here you can see a normal cell, and when the lysosomal enzymes are not fully active, if the enzyme activity is decreased, then the macromolecules cannot be degraded and excreted thereafter, and thus we see accumulation of glycosaminoglycans in the lysosomes. The lysosomes are thereafter swelling, the cells are swelling, and the cells lose their function, and with that the organs lose their function. Unfortunately, quite a number of organs can be involved, and to keep it a little bit simple, one can summarize that in the mucopolysaccharidosis, in most patients, the predominant organ system involved is the skeletal organ. We call it dysostosis multiplex, which has several aspects of the disease, including the disproportionate shortness of stature. And then about 70% also suffer from CNS involvement, which comes with behavioral defects and cognitive decline, developmental delay, and this affects about 70% of Hunter's patients, and the same is true for all MPS patients. And then, in addition to skeletal and CNS symptoms, there is a plenty of other symptoms that can be involved. The ENT system with large tonsils and adenoids, as we can see in our clinical case today, but many other aspects can also be involved, hearing loss, and so on. We have the cardiopulmonary involvement, we have the gastrointestinal involvement, and we have a classical facial features that sometimes leads us to the clinical diagnosis. However, it is important to understand that it is not so much the clinical the facial features that should be used for making the diagnosis. Rather, it should be the combination, the clinical pattern of skeletal affection, dysostosis multiplex, plus CNS involvement, plus multisystemic involvement. This should guide you in your clinical diagnosis. Further insight into the single symptoms of the disease would be beyond this webinar, so I would like to continue and just highlight very important clinical aspects of the disease. Hunter's syndrome, as well as all other types of mucopolysaccharidosis, are presented in a broad range of clinical spectrum. This means that we see very mild patients. This patient, for example, speaks 3 languages, and on the other end of the spectrum, this Hunter patient is severely impacted, cognitively impaired, but it's not black and white, and it's not just 2 or 3 boxes of non-neuronopathic or neuronopathic. It's rather a spectrum from very mild forms going to very severe forms in Hunter's disease or Hunter's syndrome, as well as in other forms of mucopolysaccharidosis. All of the mucopolysaccharidoses are chronic diseases, progressive diseases, which comes with the fact that at birth sometimes you cannot recognize the clinical, the facial features of the disease, so diagnosis is normally made at the end of the first or in the second or even in the 3rd year of age. Here in this Hunter's patient, this is the same patient at birth, and this is the patient at 3 years, and you can clearly see the facial features of Hunter's syndrome here with the lips and the nose and the forehead very predominant. And here in between, it's, I think, obvious for an expert, but it might be overseen from other physicians. So it's all of these MPS forms are chronic and progressively in the course of the disease. One other aspect which is very important for these patients is that due to the complications of the disease, basically every patient needs a lot of surgical procedures. And here you can see data from the HOS registry, Hunter syndrome outcome survey. You can see the most common surgical procedures. They are in ENT quite a bit, so tympanostomy and adenoectomy, tonsillectomy, and in addition, hernia repair and carpal tunnel syndrome is very common. Carpal tunnel syndrome, by the way, is very, very rare in pediatrics otherwise, so whenever you diagnose a carpal tunnel syndrome in a pediatric patient, you should think about mucopolysaccharidosis or mucolipidosis, because otherwise it's really very rare to find carpal tunnel syndrome. Why is it so important that these patients undergo so many surgical procedures? Because they have substantial perioperative risks which are associated with airway problems, the airway narrowing that these patients have, and this is also one reason why we started our simulation activity together with Dr. Christina Lampe and Dr. Matthias Schäfer 7 years ago. And I want to summarize a little bit now. So why are these patients under risk? It's a rare disease, and as you have commented earlier, not so many professionists involved in such a situation are very aware of the needs they have. There is many specialists, however, involved, the ENT, the anesthetists, the nurses involved, and most of them don't know too much about Hunter syndrome, and I think this is not the case only in our scenario, but in many, many centers. So many surgical procedures are needed, so the risky situation is repeated very often in these patients, and there is a lot of complication risks of these patients which are summarized here. I will not go through every point here. I just want to recommend the literature here where you can have a closer look on this perioperative risks, the risk for perioperative complications in these patients. Many of these risk factors fall into the class of difficult airways, so narrow airways, then very sensitive mucosa, a lot of problems while intubation. Tracheomalacia could also contribute to problems here. There is very much mucus and very sticky mucus, and this doesn't make it easier. So you have to prepare. One comment was prepare, not cure. Exactly. You have to be prepared for such complication situations. And I hope that the video case gave you an opportunity for experience, that you are alert now that this can happen. It's not a rare complication. It's very common that these patients have milder or more severe complications. So you need to be prepared. So other contributors to these complications have also been mentioned earlier, the cardiac manifestations, and something we have not mentioned yet is the cervical instability. This can affect all MPS patients and is most predominant in Morquio patients, type 4A patients, but you always have to have in mind that the swelling of the meninges can contribute to myelin compression. So a very strong reclination of the patient is contraindicated here. And so this is another aspect an anesthetist should know about an MPS patient. Lung disease and other aspects, spine disease, can also contribute to complications here. So what do we have to take home here? So it needs a leader of an interdisciplinary, interprofessional team to provide best planning and managing of such a surgical procedure. An anesthetist should be experienced in providing anesthesia to MPS patient, or at least it needs a very, very experienced airway manager here that is informed about the potential complication, that has done high quality preoperative evaluation, either by laryngoscopy, either by endoscopy or by imaging procedures, to know what is to be expected in this patient and to have the devices and the know-how in place to handle this patient. Sometimes it can even be necessary to have an ENT in standby in case a surgical airway is needed. Why is it so important? These patients need a lot of operations, and sometimes the diagnosis is not made before the first surgical procedure. So it is also important to know what could improve the probability of early diagnosis. And as I showed you in my introduction, it is rather a clinical pattern that has to be detected than only the facial features. So if you have shortness of stature and dysostosis multiplex or other skeletal involvement, together with CNS involvement, you should think about Hunter syndrome. If you have a lot of and very severe ENT problems, hearing loss, large tonsil adenoids, together with cognitive impairment and skeletal problems, you should think about MPS. A very comprehensive differential diagnosis of MPS and the description of many different clinical features of this disease is beyond this webinar. But keep in mind, the early diagnosis is not only helpful to bring the patient on enzyme replacement therapy and by that provide causal therapy, it is also important to provide best management perioperatively and beyond that. So I thank you very much for watching and listening. I thank you very much for these very interesting and helpful comments and questions that you sent in. I hope it was a little bit helpful, this webinar, to alert you on the risks of these patients. Maybe we see each other in Salzburg for a simulation training here in our Medical Simulation Center. Thank you very much and have a nice rest of the day. Goodbye.